All right, good afternoon, everyone. Um, Thanks for joining. I know there's a few people still trickling in, but we're going to get started here so we can stay on time. I know there's another program here to follow us. I'm Aaron Berger. I'm a urologist in the Chicagoland area, and we're going to be discussing IsoPSA, which is a breakthrough diagnostic and prostate cancer risk assessment. It's a novel approach to enhance biopsy decision making. Here's my disclosures. Today's program, we're going to be talking about stratifying risk of clinically significant prostate cancer to inform biopsy decisions. We'll go over what is the IsoPSA test, IsoPSA clinical studies, a few case studies, and then we'll take some questions if there are any at the end. We should have some time for some questions at the end. So detecting clinically significant prostate cancer is certainly the goal of any prostate cancer screening program. Finding non-significant low-grade disease is really not what we're striving for, but certainly we don't want to miss the clinically significant ones that can actually impact a patient's life. So many patients will show up to our offices from their primary doctor with a elevated PSA. Most people these days should not just be going to biopsy with one isolated elevated PSA, hopefully, but there are multiple different options as far as finding out, do those patients really need to be evaluated further? And that would include doing a repeat total PSA, doing imaging with an MRI, or moving on to an ancillary test. And there's multiple tests I'm sure you've seen here at the conference this weekend in this space, but we're going to discuss why IsoPSA has some nice advantages. For patients who do end up getting a biopsy and are found to have low-grade prostate cancer and on active surveillance, IsoPSA also can be used in the active surveillance setting to determine potentially when patients are moving forward and need to be treated and moving away from surveillance. So here's a current look at the NCCN guidelines, which I'm sure many of you are familiar with. So if patients do have elevated PSA, the guidelines are currently calling for a repeat PSA, doing a digital exam if it wasn't performed initially, working up for benign disease, and then moving forward with additional diagnostic testing, which can include MRI as well as biomarkers that can help improve the specificity of screening. So a couple kind of quick case reports or case studies to set up our discussion today. These are certainly very similar common patient situations that you may see in your offices. So case one here is 62-year-old African-American male referred by his primary care physician. His PSA of 6.2. His exam really had no findings except for some prostate enlargement, but no nodules, nothing hard or firm. His workup, again, repeat PSA 6.4%, free PSA was 13. He's got a family history of prostate cancer. He has a multiparametric MRI, which had a PIRADS score of 3. We'll get into a little bit, what that kind of means from a diagnostic and prognostic standpoint. But he's just reluctant to have a biopsy. He doesn't really want to have an invasive procedure. So this is an excellent candidate where additional testing may help get him to the correct diagnostic test that he may need. Another case, so this is a patient who's on active surveillance. So this is a patient, early last year, was getting at an elevated PSA, was found to have a grade group 1 prostate cancer. He's also being treated with BPH. He had a PSA of 12.3%, free PSA of 21. His ultrasound-guided biopsy showed Gleason 6 and 2 cores, but he's got a very large prostate of 97 cc's, which, as we know, that certainly could make the total PSA elevated just in and of the fact that he's got a 97 cc prostate. So follow-up now recently, so PSA 12.4 at a year later, and he wants to avoid repeat biopsy, and I think it's incumbent upon us not to do unnecessary biopsies if at all possible. So again, he's an excellent candidate for additional ancillary testing to really assess his risk of becoming more of a clinically significant patient that needs to be treated. So stratifying the risk of clinically significant prostate cancer to inform biopsy decisions, as we talked about, you can do repeat PSA, multiparametric MRI, or additional ancillary testing such as IsoPSA. So the repeat total PSA, certainly a lot of people do this, that has a high sensitivity. So the sensitivity for detecting clinically significant disease is about 93%. It is in the guidelines as far as the AUA, SUO, and NCCN, as we just showed you earlier. The main issue here, though, is has low specificity. So the specificity for clinically significant cancer is only around 20%. It has to be adjusted based on if they're on 5-alpha reductase inhibitors, and especially if they've only been on those for a short amount of time. Sometimes it can make interpretation very difficult. If they've started a medication, 2-3 months ago, you don't really know how to do that conversion properly. And other benign factors such as BPH, recent prostate manipulation, stimulation, prostatitis, inflammation, other benign or infectious causes certainly can make that PSA go much higher. So multiparametric MRI, this has been pretty widely used now for the past several years. Certainly a great addition to the prostate cancer screening armamentarium. Gives you good visualization of the prostate and surrounding structures. See if there's any specific lesions. Aids in diagnosis as far as disease staging. See if there's anything growing outside the capsule. If there's any regional lymph nodes involved. Potentially seminal vesicle involvement. And biopsy targeting. Many of us are doing MRI, ultrasound, fusion biopsies where you can actually target the tumor. And having the MRI certainly does provide for some treatment options now with targeted treatments, but it does still have some limitations. So the positive predictive value, as we'll show you on the next slide, just still has a very large variability. Really depends on where it's being done and who's reading it. It is subject to quality of the study and the quality of the person and experience level of the person who is reading the study. The PI-RADS scoring system is subjective. You could show the same MRI to multiple radiologists and you might get multiple different answers of what the PI-RADS score is. And it can have a significant false negative rate, up to 20%, which is certainly concerning. We don't want to be missing clinically significant disease. And as well as significant false positive rate is also a concern, but I think the previous one of missing significant disease is as or more important than potentially overdiagnosing non-significant disease. The PROMISE study, this is a study from several years ago looking at MRI and the sensitivity specificity. So this is looking at about 570 patients. For PI-RADS 3 lesions, there was a 63% false positive rate. And again, even potentially more concerning, the PI-RADS 1 and 2 actually had 11% false negative rate. So you're seeing MRI that's basically coming back negative. Most of us would not biopsy 1 or 2 lesions just by looking at the MRI results. So potentially missing 10+% patients with clinically significant disease certainly is concerning. Positive predictive value here, again, 65%. Negative predictive value, only 76% for Gleason score 7 or higher prostate cancers. This is a little more recent meta-analysis looking at positive predictive value of multiparametric MRI. And the take-home message of this study from last year was that, by itself, it's still not great. Age, PSA, exam findings, PSA density can improve decision-making. This was a meta-analysis looking at 56 different studies for multiparametric MRI, and they showed that PI-RADS 3 lesions in this meta-analysis had a positive predictive value about 13%. PI-RADS 4 was 40%, and even the PI-RADS 5 was only just under 70%. So strongly correlated with disease prevalence in the community, and also is dependent on individual patient risk factors with some of those other baseline parameters we discussed earlier. So again, it's a very useful test. It's great in combination, but by itself, it still can have some limitations, especially based on where you're having the study done and the experience level of who's reading it. So ancillary testing, as we talked, there's lots of options in this space. So it can increase specificity compared to repeat PSA, and it can aid along with a multiparametric MRI to help guide your clinical decision making. Some of the issues with ancillary testing is there can be, depending on the test, constraints to a PSA less than 10. It can also be limited to biopsy-naive patients. It can require additional inputs like DRE, clinical data, prostate volume. Some other testing requires additional inputs. And it also can be restricted if patients are on 5 ARIs for their BPH symptoms. Some of the other ancillary tests may not be allowed to be used. So that brings us to IsoPSA. So this is a breakthrough in prostate cancer risk assessment. And we'll go over the clinical data and how this may be beneficial to you and your patients. So how does IsoPSA work? So you're trying to find out, does this patient have a clinically significant prostate cancer? So really what we're looking here is the protein structure. So a normal cell makes normal PSA proteins. So when you're assessing PSA concentration, again, as we talked about, PSA is not a cancer-specific test. It's got a good sensitivity. It can be elevated for BPH, prostatitis, or other benign factors. Cancerous cells have structurally modified or isoforms of PSA proteins. So assessing the PSA structure and determining how much of these cancer-produced proteins are present can help us then guide the likelihood that there may be clinically significant prostate cancer. It's a direct measure, and it really is much more specific for cancer than a total PSA. So how IsoPSA testing works is it's a special collection container. So basically, it's separating out the PSA isoforms that are from cancer cells versus those from normal cells. And this is a blood test. It's currently approved for men 50 years and older with a PSA greater than 4. So basically, you get a blood test for these patients, and it comes out with this report here, which we'll show you a little more detail momentarily. But you do get a total PSA result, as well as what's called the IsoPSA index, which is basically a measure of how much of these altered PSA proteins from cancer cells are present in the patient's blood sample. So here's a little blow up of what you'll see on your report. So you'll get the IsoPSA index. Again, you also will get the total PSA result as well. But what's really important here is the IsoPSA index. This is what we're looking for and how this helps guide our treatment. So the risk threshold is a singular cutoff for clinically significant prostate cancer of greater than 6. So if you look down on the bottom here, you'll see if it's less than or equal to 6, the patient has a decreased risk of harboring high-grade prostate cancer. If it's greater than 10, they have an increased risk of harboring high-grade disease and suggesting further evaluation and considering a biopsy. And if it's between 6 and 10, then they are at increased risk, but it's where you want to have other clinical factors, play into the decision-making and shared decision-making process with your patient about moving forward with biopsies such as age, family history, ethnicity, and prostate MRI findings, and using all those things in combination. So the benefits of measuring PSA structure, again, this simplifies patient selection with limited exclusions. So there's no requirement when you order an IsoPSA test to have the patient history, clinical information, or a digital rectal exam findings. You can do this for Medicare patients as far as coverage currently between a PSA of 4 and 25. And BPH medications do not affect the results of the IsoPSA test. So there's greater accuracy than measuring total PSA concentration, so you get greater specificity, to better stratify the risk for clinically significant prostate cancer, and improved biopsy decision-making. Again, it can be used in combination with multiparametric MRI, and for biopsy-naive patients, you can do this, and you can also do this for patients who previously had a biopsy, whether it's a previous negative or a previous positive biopsy showing low-grade disease. So patients with a total PSA of greater than 10, you can also do this. There's not a restriction on that. So it is a wide range of patients who can get this test, and it's just a simple blood test without really much else required to order it. So going back to our initial case studies, so this was just the gentleman who was referred for a PSA of 6.2. He was a little hesitant to get a biopsy done. So he had an IsoPSA test done, which showed an index score of 12.3, which, as I mentioned, anything greater than 10 does put him at increased risk. And that, combined with his other clinical features, which you really won't even need to have other concerning features for this patient. Anything above 10 is going to be concerning and really should be considered for biopsy. But you add that into having family history, being African American, certainly this is someone you're going to want to biopsy. So he does get a biopsy showing a grade group 3 tumor in the MRI targeted lesion, as well as 4 of 12 systematic cores. So again, this is a pretty high volume patient that we were able to get to biopsy by showing him some additional data with the IsoPSA that, saying this is really something you should be concerned about. Have the discussion and let's get the biopsy done. The second case we discussed was the active surveillance patient. So again, this is someone who had the previous biopsy, and his previous MRI target lesion was negative. He's got a big prostate, and subsequently, since he had his initial biopsy, he now has gotten a pacemaker, and is on blood thinners. So, this is not someone you necessarily want to take a repeat biopsy lightly, because you can't get another MRI with his pacemaker and stopping blood thinners on someone. Obviously, you always want to be, that's a discussion you have to have with their primary care doctor, cardiologist, whatever. So he has an IsoPSA done, shows an index of 4.2, which that's going to show a decreased risk of clinically significant disease. So after discussing risks and benefits of repeat biopsy with the patient, you'd like not to do a biopsy at this time based on the IsoPSA, and this is something you can follow longitudinally. So notable patient applications for IsoPSA. So as we kind of talked about already with that initial case, so patients with initial, whether you're evaluating for an initial biopsy, if they have an elevated total PSA, if those patients are hesitant to proceed with biopsy, certainly this can be something that might get them over that hurdle. In combination with MRI, so PIRADS 1 and 2 lesions, IsoPSA can be very helpful in diagnosing the kind of invisible clinically significant cancers that MRI may miss. I think this is really we've definitely had in our practice a good number of these patients where MRI is not concerning, but IsoPSA is concerning, and we found some significant disease, and we'll show you a case of that later. PIRADS 3 tumors, which, as we've talked about, depending on who's doing it and where it's being done, can have a wide variability of positive predictive values. So this can assist in determining, in combination with IsoPSA, which men should move on to biopsy. And then in the PIRADS 1 to 3 patients can also provide confidence about avoiding a biopsy if the IsoPSA is below the threshold of 6. You can feel comfortable that we can monitor those patients. As well as we talked about repeat biopsies for patients on surveillance to monitor them to determine when they may need to move on to additional testing or additional biopsies. This is going to go through the clinical validation studies, which was published in Urologic Oncology a couple years ago. So this is a single parameter structure-focused assay for improved detection of prostate cancer. This was a prospective multi-center study. So it was a 5-year prospective study of just under 900 men who were scheduled for prostate biopsy. And the results here showed that IsoPSA outperformed total PSA and percentage of free PSA with a higher area under the curve, specificity, positive predictive value, and negative predictive value were all superior to both total PSA and percent free PSA. No statistically significant difference in sensitivity. So you're not really, you're not losing anything on the sensitivity, but you are gaining specificity and gaining both positive and negative predictive values. So conclusion here is that using selected IsoPSA index cutoffs for clinically significant prostate cancer, roughly 46% of biopsies could be avoided in low-risk patients. So again, not overdoing it as far as biopsies for patients who don't need it, and not missing the ones who are at risk. That should be really all our goal for working up patients with elevated PSA and evaluating their risk of prostate cancer. So another conclusion they did draw from this study is that IsoPSA performance was equivalent in both biopsy-naive patients as well as those who had a previous negative biopsy. As we mentioned, this is approved based on this study for patients who've had previous biopsies, because the results really were not statistically significant when you look at the various markers of sensitivity, specificity, and positive and negative predictive value were all statistically similar between the biopsy-naive and the prior negative biopsy cohorts. And IsoPSA performance was also equivalent in patients with a total PSA of either between 4 and 10 or greater than 10. So again, you don't need to, just because their PSA is a little bit higher or lower, you can still use this kind of for all comers in that 4 to 25 range is what Medicare will cover currently for testing. And your results, or your IsoPSA index cutoffs, will be equivalent regardless of where their total PSA lies. So this was a subsequent study using IsoPSA along with prostate imaging, using the Prostate Imaging Reporting and Data System score, which is also known as PIRADS. And this may help refine biopsy decision-making in patients with elevated PSA. This was published in the journal Urology, the Gold Journal, last year. So this was 270 patients who underwent prostate MRI along with IsoPSA testing and biopsy. The conclusion here was that the combination of IsoPSA along with PIRADS scores provides meaningful predicted probabilities for the likelihood of detecting clinically significant prostate cancer at biopsy. with a reassuringly low probability when PI-RADS 1 to 3 is found in conjunction with a low PSA, IsoPSA index. So if you kind of look at those shaded areas in green, so if you have an IsoPSA index of less than or equal to 6 with a PI-RADS 1 to 3 lesion, your chance of missing clinically significant cancer is only 4.5%. So it's a pretty powerful tool to try to make sure you and your patient are comfortable that we can potentially avoid doing a biopsy if you fall into those with the IsoPSA index 6 or less with a 1 to 3 PI-RADS score. Again, the PI-RADS 1 and 2 patients, you can help assess risk of presence or absence of potentially MRI invisible clinically significant prostate cancer. So 4 to 16% of PI-RADS 1 to 2 patients can harbor clinically significant cancer. PI-RADS 1 and 2 with an IsoPSA index of 6 or less had a negative predictive value of 98%. IsoPSA index of greater than 6, there was an 8% predictive probability of finding clinically significant prostate cancer on the biopsy. So even with those MRI reports where it says, nothing there, PI-RADS 1, if their IsoPSA index was above 6 in this study, there was still an 8% likelihood of finding clinically significant cancer. So again, this shows how this can be a powerful tool to make sure we're not missing any bad disease. And as far as the PI-RADS 3, this can also help you gain additional insights to triage patients. So those with a IsoPSA index of 6 or less, there's a negative predictive value of 96%. If it was greater than 6, again, 16% probability of finding clinically significant cancer. So depending on where you are, what your protocol is with PI-RADS 3, if you have a higher IsoPSA index, those are patients you really should be discussing biopsies. Certainly those patients with PI-RADS 4 and 5 lesions, most of us are going to be biopsying those patients kind of regardless of what any additional ancillary testing is going to show. So this is looking, again, IsoPSA performance characteristics are unaffected by 5-alpha reductase inhibitors and alpha blockers. So certainly a lot of these patients we're evaluating for prostate cancer have BPH and have lots of other urinary symptoms and are on medications. So you can be confident that based on this study that there is no difference in performance of IsoPSA, whether they're on alpha blocker, whether they're on 5-ARI, whether they're on both. You can still be confident that your IsoPSA index is still going to be a valid test and can be used in all the ways we've discussed as far as making your clinical decisions about moving forward with biopsy or not. So this was actually an abstract that was presented yesterday. I don't know if anyone saw this abstract, but this is looking at the natural progression of patients with an IsoPSA value and its predictive ability of clinically significant prostate cancer and biopsy. So again, this is looking at checking IsoPSA in a more longitudinal fashion. So basically, this is comparing longitudinal outcomes of eventual biopsy and imaging of surveilled patients with initial IsoPSA of 6 or less versus those with IsoPSA greater than 6, and assessing the prospective predictive ability of IsoPSA for clinically significant cancer. So at 24 months of follow-up, only 4.3% of patients who had an IsoPSA of 6 or less developed clinically significant cancer, whereas 35% of patients with IsoPSA greater than 6 went on to develop clinically significant cancer. So again, this is showing that this is a powerful tool. If that index score is elevated, this is someone you need to be concerned about. So let's look at a couple more case reports here, and how this can really be utilized in your practice. So as we touched on earlier, convincing the PSA skeptics and those that maybe not want a biopsy. So there's a 58-year-old male being treated for BPH, PSA of 6.1. His exam was normal other than some enlargement. We discussed doing additional workup, but the patient was reluctant. Obviously, he went on the internet and saw all the stuff about how PSA is useless and we shouldn't be screening or doing anything else with PSA based on data and nonsense from 10, 15, 20 years ago. But we counseled the patient that his concerns may have some merit about total PSA and its utilization and screening, but that we have some better options and some newer techniques that we can do to help determine his actual risk. So now he's refusing an MRI due to some claustrophobia, which certainly is not that uncommon. And we explained that IsoPSA can help better stratify risk, and that recommendation would be to do a repeat PSA with an IsoPSA, and he's now amenable to doing the repeat blood testing. And his total PSA and repeat is 6.8, but he has an IsoPSA index of 9.4. So he was then amenable to proceeding with a biopsy, which did show 2 out of 12 cores of grade group 2 disease. So clinically significant disease where the IsoPSA really helped to convince the patient that what he reads on the internet, not everything there is true, which is certainly a problem we all have in our practices. Another patient here, so this is a borderline biopsy based on PSA and multiparametric MRI. So 67-year-old male with an elevated PSA, no family history. So PSA is 4.5, so 67, you're kind of right on the borderline there of being above normal. He has an MRI which showed a PIRADS 3 lesion. So again, as we've talked about, the predicted value of that is you know, not extremely high. So we did order an IsoPSA for this gentleman. So total PSA here, 4.7, so very similar, but IsoPSA index of 15.2. So this is a very high-risk patient. So he undergoes an MRI ultrasound fusion biopsy that showed grade group 2 disease in the target lesion, but grade group 3 disease in 4 systematic cores. So again, high IsoPSA index, you know, someone at 67 with a PSA of 4.5, which, you know, most of the reference ranges is going to say 4.5 is on the upper limit of normal, but no family history. So this is someone that may have very well just been missed or delayed. So certainly in this case, the IsoPSA index is going to help us a great deal in saying, hey, this is high risk, we need to do a biopsy. Another example of an active surveillance patient. So it's a patient with grade group 1 disease who does have a family history. So initially worked up in 2022 with a PSA of 7.2, had a PIRADS 2 lesion, so basically a negative MRI with a relatively small prostate, 37 cc's. Systematic biopsy at that time showed 3 out of 12 cores of grade group 1. PSA then went up a little bit, 6-month follow-up, and then 6 months later, his PSA is now 7.5, and his MRI is now showing a PIRADS 3 lesion. And confirmatory biopsy, again, shows a grade group 1 lesion. Now his PSA has gone up a little bit higher to 8.7. So we say, why don't we do an IsoPSA test to really determine your risk of clinically significant disease, since he's already had 2 biopsies showing grade group 1 prostate cancer. He's trying to avoid another one. So here his PSA was 9, IsoPS index, however, of only 4.3. So with two biopsies showing grade group 1 disease, MRI showing no 4 or 5 PIRADS lesions, and an IsoPSA index of 4.3, this is someone I think we can be comfortable saying we can just continue surveillance, keep watching you, and we'll continue testing, and maybe this would be a good candidate that could have longitudinal testing as we just showed in that last abstract. And identifying significant cancer with normal multiparametric MRI, you know, this is certainly not the most common scenario, but IsoPSA may be helpful, and I think it's really one of the most important utilizations of IsoPSA and how it can really help patients. So this is a patient with a PSA of 4.8. He had an MRI done saying that there was no findings suspicious for cancer and a volume about 36 cc's. We discussed and ordered an IsoPSA for him. So his repeat total was 5, but IsoPSA index of 18.3. So this is someone that your alarm bell should be going off. There's something going on here. So we recommended just doing a standard biopsy since the MRI had nothing to target. And this showed 5 out of 12 cores that was grade group 4 disease in his systematic biopsy. So again, this is someone borderline PSA, you know, maybe doesn't want to have a biopsy. MRI's negative, so you say, oh, your MRI's negative, let's just do nothing. I mean, this is someone, if you wait 6 months and check their PSA again, he certainly could move on to have, you know, locally advanced or metastatic disease by waiting that 6-month period. So there's another instance where IsoPSA, again, not the most common scenario, but certainly one that is very important as far as identifying high-risk patients. So the PSA pathway that we're using in our group, we've been using IsoPSA for last couple years. So patients who do have an elevated total PSA will repeat it using the IsoPSA test. If the IsoPSA index is elevated, then we'll discuss moving forward with doing a multiparametric MRI. If there's a contraindication to an MRI, or if the patient refuses, then we'll discuss doing a standard systematic biopsy. If the multiparametric MRI shows PIRADS 3 and the IsoPSA is elevated, we'll go ahead and do a MRI-guided biopsy. If there's a PIRADS 3 and the IsoPSA index is less than 6, then the biopsy decision will be made on other factors such as age, family history, factors like that, ethnicity. If there's a PI-RADS 4 or 5, we'll do an MRI biopsy kind of regardless of what IsoPSA index says. And if MRI is negative, where it says 1 or 2, or a lot of reports will say no clinically suspicious findings, but the IsoPSA is concerning, which is kind of that last case study we just looked at. Especially if it's greater than 10, then we'll recommend doing a standard systematic biopsy to try to find those invisible high-risk cancers that the MRI is just not seeing for whatever reason. So in summary, IsoPSA simplifies patient selection with limited exclusions. This does not require patient history, clinical information, or a DRE information. Patients currently, at least Medicare population, are approved for this with a PSA between 4 and 25. And BPH medications do not affect the results, and it can be done for patients who've previously had a biopsy before. It does have greater accuracy than measuring total PSA concentration, with greater specificity to better stratify the risk of clinically significant prostate cancer, and it can help improve biopsy decision making in combination with MRI, and it can be used again for biopsy-naive patients or those considering repeat biopsy, and can also be used for patients who have a total PSA of greater than 10, which is a limitation of some other studies in this space. So with that, the booth's 1113 if you need more information, and I appreciate your attention and happy to take any questions if there are any. Thank you. All right, thank you very much. Enjoy the rest of the afternoon.